Hi everyone, Red Safavi, and I feel your pain. I know the board is there, and psychiatry is probably not the most fun aspect of the board, but we're going to just storm through it and go through it. So, today we are going to talk about different aspects of psychiatry. I will try to give you an overview of psychiatric conditions in general, because working with internists and family practice doctors, I get this question a lot, that what's the difference between adjustment disorder and depression? What's the difference between schizophrenia and bipolar with psychosis? So I'll go through the psychiatric condition and an overview to just give you how a psychiatrist's brain works. Sometimes it's different from other brains. And then we'll go over mood disorders, briefly talk about suicidality, touch on anxiety disorders, not a very difficult topic. We will switch to psychosis, schizophrenia, related disorders, and then we'll focus some time on psychiatric medications. And then after that, we will touch on personality disorders, substance use disorders, sleep-related issues, and then finally, other topics in psychiatry that might show up on your board. So when you're talking to a psychiatrist, you focus on symptoms. And we have DSM, which is a classification of psychiatric symptoms. But when you're looking at a psychiatric condition, you shouldn't only look at the symptoms at the moment. There are other factors of the disorder that are very important in making the right diagnosis and choosing the right treatment. Age of onset is very, very important in psychiatry. Some disorders like schizophrenia show up around age 20. So if you're talking to a psychiatrist and you have a 25-year-old guy with psychotic features, the psychiatrist say, oh yeah, absolutely, schizophrenia, transfer to psych floor, we'll treat it. Versus if you have a 65-year-old guy with no history of psychosis and talking to a psychiatrist about how to treat it, the psychiatrist is going to be like, absolutely not. This is not a schizophrenia. This is something else. Let's see what it is. Also, in psychiatry, the duration of symptoms are very important. Has the patient been psychotic for 1 day versus 1 month versus 1 year? And also, every psychiatric symptom has a causative agent. The causative agent might be the disorder by itself. It might be schizophrenia in psychosis, but it can be a substance, a medication, or a medical condition. Psychosis might be just a symptom of another medical condition. So in psychiatry, we focus on what is causing the symptoms. And also, it is very important to look at the decline in the functionality of the patient. Everybody suffers from a little bit of anxiety here and there. Everybody suffers from a little bit of depression here and there. But it is very important to focus how that psychiatric disorder is changing the functionality of the patient. And also, it's important to look at any recurrences in the course of the disorder. There is a joke in psychiatry. They say once you have a psychiatric diagnosis, you have it for life. If you have MDD, major depressive disorder, you have it in life, but after the episode resolves, it goes in full remission. Versus when it comes back, it goes into recurrence. But once you have the disorder, it's for life. And that's that last box, recurrence indicates. And we will come back to this image through this course and talk about how different psychiatric conditions change based on this image. So the most common psychiatric disorder as primary care providers or internists or non-psychiatric providers you will face are mood disorders. And the most common one is MDD, major depressive disorder. All of us might wake up from a nap one day and feel a little bit down, feel a little bit depressed, but the key factor of major depressive disorder is that episode of feeling down and depressed has to last at least 2 weeks. And it has to have depressed mood or anhedonia, either or. And anhedonia is defined as a significant decrease in interest. In addition to that, you need to have at least 5 or more of these other psychiatric symptoms: sleep disturbances, changes in interest, feeling guilty, any changes in energy and not being able to concentrate, also changes in appetite, overeating or undereating, and also changes in psychomotor energy, like the patient becomes very psychomotor retarded, not moving, versus very psychomotor agitated, and also suicidal thoughts. So again, back to that image, back to that figure, the duration of MDD has to be at least 2 weeks. A few facts about MDD. The lifetime prevalence is about 20%, 1 out of 5. So all of us will face patients who suffer from MDD. The chance of relapse after the first episode or recurrence is about 50% and 80% after third episode. 80% of patients, they actually gain a very significant reduction in their symptoms with appropriate treatment. And on the other hand, 50% of the patients might not respond to the first treatment, and you need to consider a change in approach. When you are assessing depression, keep in mind, back to the figure, it can be caused by just being depressed, or it can be a social event, or it could be another medical condition or substance use. So when you are working up depression, you need to think all 3 aspects: medical, psychiatric, and social history. Also, please assess for any thoughts of hurting themselves or somebody else. Please assess for substance use, perform a physical exam, get some labs done, and also there are medications that the patient might already be on it for other conditions that are causing the depression. And one of the medications that I see a lot and might show up somewhere soon are interferons, especially with hepatitis C patients. About the majority of patients who get that treatment, they have significant depression. Doing the lab workup, there are routine labs that you guys get in clinic, a CBC, liver panel, a UA, check the urine for substance abuse, also focus on vitamin Bs, and also think thyroid. And also RPR and HIV are routine labs that we frequently check in psychiatry, and also pregnancy tests. So when it comes to treatment, psychotherapy and or psychopharmacology are the approaches to take. You can take both. However, if after recommending psychotherapy and or medication after 12 weeks, the patient does not respond, you need to change approach. I highly suggest the first 8 weeks of the treatment, do routine follow-up with the patient, either over the phone or in-clinic follow-ups every 2 to 4 weeks. If the medication trial is not responding, you might consider changing it. And keep in mind that about 10 to 30% of patients have treatment resistance. And if you have any concerns about presence of hypomania versus mania or psychosis, or you've tried multiple medications and the depression is not getting better, please consider consulting a psychiatrist. And also remember, in psychiatry, the only emergency is thoughts of hurting yourself or somebody else. So if there are components of suicidality or homicidality, please seek immediate psychiatric consultation. So treatments. SSRIs are the first line of treatment. There are multiple medications in this class. SSRIs are also very effective in treating anxiety disorders. They may cause a little bit of weight gain, not as much as other antidepressants. Also, some GI side effects, including diarrhea or vomiting, are common. They usually resolve in 1 to 2 weeks. So if you tell your patient, take your pill with food, they usually resolve. On the other hand, changes in sexual function are not dose dependent, and if they show up, they're probably going to stay and they're not going to resolve. In that case, you can consider either changing the medication, or if the patient is responding very well to medication, you can add another medication to address the sexual side effects. And the most common medications that we use are bupropion and mirtazapine. And in elderly, there is a slight chance of GI bleed in patients on SSRIs, especially the ones who are on NSAIDs or aspirin. So we have a question. A 65-year-old male presents with 4 weeks of depressed mood, poor sleep and appetite, and anhedonia. He denies any suicidal thoughts. He is diagnosed with MDD and agrees to start a trial of medication for his symptoms. Which of the following medications is more likely to cause QTc prolongation in this patient? And the options are fluoxetine, sertraline, paroxetine, citalopram, and S-citalopram. And the right answer, as most of you chose, is citalopram. For the purpose of your board, please just keep in mind, one of the SSRIs show up a lot with the side effect of QTc prolongations, and that one is citalopram. S-citalopram, option E, is a derivative of citalopram, but that one, the data did not show any changes in QTc. So for the purpose of the board, just keep that in mind. There are zebras in psychiatry, so I listed all the zebras for SSRIs for you. Remember, the longest half-life SSRI is fluoxetine. The shortest half-life is fluvoxamine and paroxetine. Paroxetine tends to show up on questions on the board often. Most SSRIs are not sedative except paroxetine. Paroxetine also causes the highest amount of weight gain, and the QTc topic again here, it can cause, citalopram can cause QTc prolongation. There are other medications in the market for treatment of MDD. Another class of medication are SNRIs, serotonin and norepinephrine reuptake inhibitors. Just like SSRIs, they're also used for treating anxiety, and they are also effective in treating neuropathic pain, fibromyalgia, and other chronic pains. Just like SSRIs, they can cause a little bit of weight gain, and just like SSRIs, they can cause some decrease in sexual functionality. Question number 2. All of the following medications belong to the same class of antidepressants except fluoxetine, duloxetine, citalopram, sertraline, paroxetine. You're absolutely right. Almost all medications that end in oxetine are SSRIs except duloxetine. The way I remember it starts with DU, like dose, It affects two neurotransmitters. It's the only oxytocin that is not an SSRI. It's two. Other treatments in the market, MAOIs, they are not first-line treatments in psychiatry. As a matter of fact, I don't think you will see a patient that goes to a psychiatrist for depression and that would be the medication the psychiatrist start. The neurologists use the medication more than us. They can cause significant amount of weight gain, more than SSRIs. They can also cause significant amount of sexual dysfunction. When you're thinking MAOIs, you should also think diet. Remember step one, you should think diet and tyramine. And when you're thinking MAOIs, even though they don't have serotonin in the name, you should think serotonin. If you go too high on the medication too fast, it can cause serotonin syndrome. We'll discuss serotonin syndrome a little bit later. And also, a very important key factor with these medications are if you are switching from an MAOI to another serotonergic medication like SSRI, or the opposite, switching from SSRI to an MAOI, to prevent that serotonin syndrome, you need to give 2 to 4 weeks of washout period. And how to choose 2 weeks versus 4 weeks, it depends on the half-life of the medication. The longer half-life, give it 4 weeks. The shorter half-life, give it 2 weeks. TCAs, another class of medications that psychiatrists used to use a lot, but no longer. It is not the first-line treatment again. It is used often by neurologists for off-label use in treating migraine and chronic pain. They can also cause significant amount of weight gain, more than SSRIs and SNRIs. They can cause sexual dysfunction, and they're very sedative because of their anticholinergic properties. And a very important thing to remember for the board is the cardiothoracic aspect of TCAs. So when you're thinking serotonin, all the medications we talked about so far, they affect serotonin. First of all, serotonin is good for depression and anxiety. So if you have a patient with depression and anxiety, you probably want to touch their serotonin system. On the other hand, brain is not the most serotonergic organ in the body. As a matter of fact, it is the third one. The first one is the GI tract. So if you're targeting serotonin, you're probably touching the patient's GI tract also. And platelets. Serotonin is an important part of platelet activation. So if you are blocking that serotonin, you are blocking that platelet activation. And sexual dysfunctions are also common when it comes to serotonin. And also think sodium for the purpose of the board. If you go too fast and too high on any serotonergic medication, you have an increased risk of hyponatremia. And every time you have sodium, you think QTC, you think cardiac muscle, you think cardiac toxicity. So in back of your head, keep in mind, citalopram, prolonged QTC, and TCA's cardiotoxicity. Another medication that is used a lot in psychiatry for treatment of depression is bupropion. This medication is not serotonergic. It is a norepinephrine dopamine reuptake inhibitor. So it does not interact with serotonergic medications. It is safe to give an SSRI with bupropion at the same time. It is also very effective in treating tobacco use. Because of the dopaminergic properties of the medication, in psychiatry, we use it a lot for treating ADHD instead of stimulants. However, a common side effect of the medication is insomnia. As opposed to SSRIs, this medication can cause some weight loss. It does not cause any sexual dysfunction. As a matter of fact, if I have a patient on an SSRI who has responded very well in terms of treating the depression, and the only problem is a little bit of sexual dysfunction, I would not stop the SSRI. I would add bupropion on top of it to fix the sexual dysfunction. The only two counterindications when you are giving bupropion is a history of seizure disorder. It decreases the threshold for seizure, and also in eating disorder patients. Mirtazapine is another antidepressant, is used a lot in geriatric patients. It is a presynaptic alpha-2 antagonist, and what it does, it kind of enhances indirectly the function of other neurotransmitters. It has a faster onset of action compared to SSRIs or other antidepressants. If other antidepressants, you have to wait for 4 weeks for the medication to work, but this one, it works faster. You could also use it as an augmentation agent when combined with other antidepressants. It helps with sexual dysfunction in SSRIs, so you can consider using this medication. It is very sedative, and it also increases appetite. And the other thing about mirtazapine is that the drug-drug interaction with mirtazapine is much less than other antidepressants. So it is usually my to-go drug in geriatric patients who are already on 10 medications for other medical conditions. They're having poor appetite, not sleeping well, they're feeling depressed. I target everything with mirtazapine. And also trazodone is one of the antidepressants that we don't use anymore for antidepressant properties. The right dose for treating depression for trazodone is probably 300 or 400 milligrams. And I'm pretty sure by experience, you know, any patient on that high of a dose is going to be asleep 24 hours. So not a very effective antidepressant. It is used for off-label purposes a lot by non-psychiatrists as a sleep medication. It increases appetite, and of course, for the purpose of the board, just like in step 1, remember, in rare cases, it can cause priapism. So question number 3, a 30-year-old woman presents with symptoms of depression. She has been treated successfully for depression in the past, but gained 20 pounds on therapy and is reluctant to take medication because of fear of weight gain. Which antidepressant would be the best option for her in regard to her concerns about weight gain? Amitriptyline, paroxetine, mirtazapine, bupropion, and fluoxetine. Perfect. Bupropion, the take-home point is, it is the one antidepressant that does not cause weight gain. It helps with weight gain. So, as primary care providers or internists, the topic of weight gain will come up a lot with your patients and depression. And so I put this slide there overall, classifying antidepressants, all of them, from least likely to cause weight gain to the most likely. Bupropion, very unlikely, it causes weight loss. SSRIs, I put 1+ in front of them. SNRIs, 1+. They cause a little bit of 2 to 5 pounds weight gain, with the exception of paroxetine, which causes more. Paroxetine and mirtazapine, they can cause 5 to 10 pounds. And TCS and MOIs cause a lot of weight gain. When you are thinking SSRIs and antidepressants, you should also think about SSRI discontinuation syndrome. If you go too fast, if you drop very fast, the patient might experience some symptoms of withdrawal from the antidepressant. The time course is usually 1 to 7 days after stopping the medication. So if you have a patient coming to your clinic 4 weeks after stopping the medication and having some of these symptoms, that's probably not withdrawal. The symptoms are mostly dizziness, headache, feeling some electric shocks, sensation going through the body, irritability, and poor sleep. It is very common with very short half-life SSRIs. With longer half-life medications, you don't really experience it. For the purpose of the board, paroxetine is the most common medication that causes this. And the way to treat it is either, well, not to treat it, to prevent it is to choose a longer half-life medication. So if you stop it, the patient probably would not experience withdrawal. And also, if you're stopping the medication, go slow. And between every change of dose, give 5 half-lives. We'll switch a little bit to other mood disorders. So bipolar disorder. What is bipolar disorder? If you think of MDD, depression, as unipolar disorder or unipolar depression, those are patients who are feeling down most of the time. As opposed to that, bipolar is the patient who is feeling down most of the time, but once in a while they jump up to the other pole, which is hypomania or mania. So this is a patient who fluctuates in mood in between. It is a chronic disorder. The lifetime prevalence is about 1 to 4%. Men and women are equally affected. The onset of the disorder is most of the time before age 30, and the first episode is mostly depression. That's why in the depression slide, I had the recommendation for you that if you're treating a patient with depression and start them on a medication, follow with them by the phone or in office, visit every 2 to 4 weeks, because most of bipolar patients, the first presentation is depression. They show up to your office, they're feeling depressed, you start them an SSRI, and 4 weeks later, they're manic. There is about 10-fold increase in risk of bipolar disorder in first-degree relatives, and also about half of bipolar patients, they experience some psychotic symptoms, which defines the diagnosis bipolar disorder with psychosis. In terms of assessing a bipolar patient for mania, think dig fast. In a manic episode, there is an increased distractibility. The patient is distracted very easily, very irritable, very increased goal-oriented activity. These are the patients that you're talking to, and they're telling you for past 3 days they've been hanging pictures on the wall, and 4 in the morning their neighbor was very upset because they were banging on the wall to hang the picture. There is flight of ideas, very racing thoughts. It's very difficult to focus on one topic. Their mind jumps from topic to topic. Significant increased activity, social, sexual, or occupational. It's a guy who's been working for 48 hours non-stop without sleeping. Significant decrease in need for sleep. So I'm pretty sure we all have gone through episodes in our life that didn't sleep for one night, but you felt very tired after it. In mania, it's decreased need for sleep. It's a guy who has not slept for 3 days, and you ask them, are you feeling tired? And absolutely not, I'm full energy, I don't feel tired. And then there is increased talkativeness, very rapid and pressured talking. So when you're assessing a patient for bipolar disorder, again, please think psychiatric history, social history. Bipolar patients actually have higher rate of suicide than depressed patients, because when you're very depressed, you might have no energy to even hurt yourself. But if you are depressed most of the time and suddenly become manic and you suddenly have the energy, you have the drive, you have the energy to do it. Please do the routine lab workup, physical exam. Some medications can induce bipolar disorder. Antidepressants are the most common. Steroids can cause that. Stimulants can cause that. I would keep antidepressants in the mind. The lab workup for bipolar disorder is the same for depression. So there is always the question of what's the difference between bipolar disorder, bipolar 1 and bipolar 2, back to the graph, think for bipolar disorder, the age of onset is before 30. So if you have a 65-year-old guy for the first time looking very manic, it's probably not bipolar disorder. The difference between bipolar 1 with manic episodes and bipolar 2 with hypomanic episodes is the duration. A manic episode has to last at least 7 days versus a hypomanic episode lasts 4 to 6 days. And also in terms of changes in functionality, a manic patient with bipolar 1 has significant drop in functionality versus a bipolar 2 hypomanic patient, they might not experience that. And in terms of recurrence, there is a about 50% chance of recurrent of another manic episode within 2 years from the first. So in terms of treatment, please keep in mind, a bipolar patient is suffering from depression most of the time. So I don't want to give you guys the message that if you have a bipolar patient, you should not treat that depression because that depression medication can push them into a manic episode. That depression needs to be treated, but it should be added to a mood stabilizer to prevent the manic episode, or an antipsychotic for an acute, to prevent, or if the patient is already in acute mania, to control that acute manic episode. The common medications, we will just touch on them because you will see some patients on these medications. Lithium is the most common one. It is the only mood stabilizer that can decrease risk of suicidality. Other mood stabilizers don't do. And also, I listed some of the side effects of lithium. When you're thinking lithium, think thyroid. Other medications that we use a lot in bipolar disorder, valproic acid. Keep in mind, valproic acid is metabolized by the liver, so continue checking the liver function every 6 months. And also with pregnant patients, try to stay away from it. Another mood stabilizer is lamotrigine. The key word with lamotrigine is Stevens-Johnson syndrome. If you start the patient on this medication and go up very fast, you might have Stevens-Johnson, and the take-home is to increase the dose very slowly. And if you have a patient who was stable on the medication and they stopped it for 1 week, and you want to put them back on the medication, you need to go slow again. You cannot just go back to the dose. Carbamazepine is another mood stabilizer. One life-threatening side effect that you can have from the medication is SIDH. The other way I remember what SIDH stands for is sodium is always down here. So that's the way I remember the name. Sodium is always down here. You have hyponatremia. The very interesting factor to know about this medication, and for that reason, it's not my favorite one. I don't usually put patients on it. The medication is an inducer of P453A4. It is also metabolized by the same enzyme. So it induces the same enzyme that metabolizes itself. So you get a lot of dose or serum concentration variation with this medication. Another bipolar-related diagnosis is cyclothymic disorder. This is just your typical patient that for the past 2 years has the episodes of depression but doesn't have all the criteria for depression, has a little bit of hypomania, but remember hypomania has to be 4 to 6 days, experiences high energy for 1 or 2 days, and also the symptoms can cause some changes and impairment in functionality. And in terms of treatment, I didn't go through treatment or diagnosis because I don't think it will show up on your test. Substance-induced mood disorder is a very important topic that will come up in terms of variation or duration of the course of the disorder, it highly depends on the substance that has caused it. The causative agent can be a recreational drug or it can be a medication. So question number 4, a 65-year-old male with history of Parkinson's disease and levodopa has no known past psychiatric disorder. He currently lives at a nursing home and has been brought in by the nursing home staff for 10 days of increased energy, singing loudly at night, erotic behavior, and hypersexuality. He visits his neurologist 2 weeks ago, and his levodopa dose was increased for better management of his tremors. What is the appropriate management of this patient? Start a mood stabilizer. He's depressed. Start an antidepressant. Refer the nursing home staff to therapy. Decrease the levodopa dose, or start an antipsychotic. Absolutely, decrease the levodopa dose. Remember, back to the chart, this is a 65-year-old guy with no psych history, so the idea of him suddenly at age 65 becoming bipolar or having bipolar disorder is very unlikely. So you have to think other diagnosis. And levodopa is a dopaminergic medication that can cause those manic or even psychotic symptoms if you go too fast on the medication or too high. The same concept with substance-induced psychiatric disorder. Some psychiatric conditions may be due to another medical condition. The duration changes based on the causative agent. The causative agent might be a medical condition, anemia, hyper or hypothyroidism, renal failure, or cancer. A diagnosis that is becoming very popular on most exams right now is premenstrual dysphoric disorder. The key words to remember, the duration of the symptoms are correlated to the luteal phase of menstruation, and they occur every time menstruation occurs. Question number 5, a 35-year-old G2P2 female with regular menstrual cycles presents with 10 to 12 days of mood swings, irritability, lashes out verbally at her husband before every menstrual cycle. However, her symptoms completely resolve within a day of menstruation. What is the appropriate first line of treatment for her condition? Continuous daily fluoxetine, intermittent daily paroxetine for 2 weeks before menses, cognitive behavioral therapy, continuous daily lithium, or continuous daily spironolactone. The right answer is actually B. This is one of those zebras of SSRIs. Remember, an SSRI, for it to work, you have to give it 4 to 6 weeks for it to work. This is the only condition that actually you can dose it intermittently for 2 weeks before the menses. We don't know why it works that way. We don't know why it doesn't need that 4 to 6 weeks of becoming effective. But with this disorder, you can just, if your patient has regular menses, you can just dose it for 2 weeks before the periods, and after the period, tell them stop till next time. Suicide assessment is a very important topic that comes up, and if it is serious, you should highly consider sending the patient to the emergency room for a psychiatric assessment. When you are talking about suicidality with your patient, also there are other key factors that you need to keep in mind. One is, how active are these suicidal thoughts? Is the patient reporting that I actually have a plan, I have a gun, I'm going to shoot myself, or this is just some passive suicidal thoughts? The patient telling you, my wife passed away a year ago. I just sometimes feel I wish I was with her, I wish I was dead, but there is no actual intention or plan. There are risk factors that change suicidality. Male gender is a big risk factor. The chance of suicidality goes up at age below 25 or age above 60. It's more common in Caucasian patients. In terms of psychiatric conditions, bipolar is actually at higher risk than depression, than higher risk than other psychotic disorders. The number one key, most important key factor, risk factor in assessing suicide risk assessment is previous attempts, also family history of suicide, access to lethal means, substance use, and lack of social support or ongoing chronic medical conditions are key risk factors. When it comes to suicidality and medication, the take home I want you to have is there is a FDA black box warning about SSRIs increasing suicidality and suicidal behavior in children and adolescents. When you are suggesting that medication to your patient, if they're an adult, the FDA warning does not apply to it. Lithium in bipolar patients is the only medication that decreases risk of suicidality, and clozapine in psychotic disorders is the only medication that is proven to decrease risk of suicidality. So those three key points. Anxiety disorders, very straightforward. I'm not going to spend too much time on it. What's a general anxiety disorder? You're feeling worried, you're feeling anxious for more than 6 months. Done. Panic disorder, suddenly out of the blue, out of nowhere, everything's good, you suddenly feel panicking. That's the word the patient gives. Pretty simple, pretty fast. Other keywords that might come up, agoraphobia, it's Greek for fear of the market. Agoraphobia is the patient who has panic disorder, and in some situation they anticipate a panic attack coming, and they go through thinking process that if I'm in a crowded place and I have a panic attack, can I run away? Can I escape? The agoraphobia is anticipating a panic attack coming and not being able to run away. A social anxiety is just fear of being in a social setting. Specific phobias, being afraid of one specific thing, one object, or one situation. Anxiety disorders are more common in females than males. As medical providers, there are a lot of medical conditions that can mimic anxiety disorders. Thyroid disorders are very common. Arrhythmias can look like a panic attack, so EKG would not be a bad idea. Asthma can mimic panic attack. And in terms of treatment, you kind of treat it the same way you treat depression. And for therapy, you use cognitive behavioral therapy. One key point that I want to give you right now is that if you see a psych question and the answer is therapy, the right answer is cognitive behavioral therapy for everything, except one thing that we'll come up with later. By borderline personality disorder, DBT, everything else, CBT. Another very common topic that comes up is trauma-related stress disorder. This is kind of mood symptoms, irritability, and sleep disturbances. That idea of fight or flight coming up after a traumatic event. The only difference you need to know is in acute stress disorder, it happens 3 to 30 days after the event, versus PTSD, there has been already at least 1 month past the traumatic event and patients start having these symptoms. I don't think you need to know the criteria for diagnosing PTSD. Just remember the prevalence is about 3 to 9%. As a matter of fact, it happens more in female patients than male patients. Because of war and PTSD, we always think male veterans and PTSD, but it is more common in women. And up to 75% of military veterans can experience it. There are 4 components of PTSD in terms of symptoms: mood and emotional symptoms, irritability, sleep-related symptoms and nightmares, and also hyperarousal or hypervigilance. And in treating PTSD, we try to focus on all these 4 areas of the disorder. Again, CBT, cognitive behavioral therapy, is the right answer. We also have exposure therapy, which is going through the event with the patient over and over and over, try to desensitize them to the event. In terms of medication, SSRIs and SNRIs are used for treating the mood aspects of the disorder, and prazosin is used a lot for treating the nightmares. I highly suggest that stay away from benzos. You might see a lot of patients, mostly in rural areas, that the patient has PTSD, goes and sees his primary care provider, and the primary care provider starts the patient on a benzodiazepam, and actually that worsens the disorder. Adjustment disorder is another topic that might come up. Long story short, what it is that you have one event happening in the life of the patient, and after that event, the patient is having some emotional or behavioral response to that event. They're having a hard time adjusting to that event. It can be with the features of depressed mood, or feeling anxious, or being irritable and disturbance of conduct, or a mixture of those. The only thing to remember, you have one event and patient is feeling or acting differently after the event. Back to the chart, the causative agent is a major stressor. There are 2 forms of it. I don't think you need to know. Is acute, which is up to 6 months, or persistent, which is more than 6 months. Okay, so we're going to switch gears to schizophrenia and psychotic episodes. So I get questions a lot from internists that what's the difference between brief psychotic disorder versus schizophreniform versus schizophrenia? It is the duration of that psychotic symptoms. In a brief psychotic or acute psychotic disorder, it is less than 1 month. If it is 1 to 6 months, we call it schizophreniform. And if patient is experiencing psychotic features and psychotic symptoms more than 6 months, it is schizophrenia. The prevalence is about 1%. Occurrence is equal in male and females. They have an increased risk of suicide. There is a very high prevalence of tobacco use in schizophrenia patients. About 80% of patients with schizophrenia smoke tobacco. A very important take-home, age of onset in men is 15 to 25 years of age, and in females, 25 to 35, which is back to my point. If you are the inpatient internist and you have a patient age 60 and having psychotic features, and you call the psychiatrist and say, I have a schizophrenia patient, the psychiatrist is probably going to be like, no, look for something else. There is a form of schizophrenia that is mentioned in your core, but I don't think will show up on your test, is late onset schizophrenia. It is very rare. I've seen it myself in only once or twice. It happens in women age above 45, and they become very delusional, but I don't think you will see it on your exam. When we are talking about symptoms of schizophrenia, there are 3 different symptoms. We call them positive symptoms, negative symptoms, and cognitive symptoms. Cognitive symptoms, it explains itself by itself. Cognitive decline. Positive symptoms, think of them as positive. There are things that you don't have, but the patient has. They're added to you to become the patient. Auditory hallucinations, visual hallucinations, delusions, those are the things that you don't have, but they're present in the patient. Negative symptoms are things that, as a normal person, as a person who is not suffering from schizophrenia, you do have, and the patient is lacking. It is subtracted from the patient. Emotions, social functionality, those are the negative symptoms. When you are assessing a patient for schizophrenia, just like any other psychiatric condition, think of social history, psychiatric history, suicidal thoughts, substance use, do your lab workup, do your physical exam. When you're thinking medications, also think corticosteroids. They actually can cause psychotic episode in patients who have no psychiatric history. Same lab workup. Substance-induced psychosis, very common. Duration changes based on the nature of the substance. The causative agent can be recreational substances or medications. A very common medication that in the psychiatric emergency, substance that I see a lot in the psych emergency room is cannabis. It increases the chance of psychosis in any individual about 2 to 3 times. Also, psychostimulants, cocaine, methamphetamines, they increase the chance of psychotic episode by 10-fold. Psychosis due to another medical condition, again, duration varies based on the medical condition. The causative agent, cancer, lupus, dementia, and hyperthyroidism are common causes. Lupus is actually one of those interesting ones because you treat it with the steroids and you have a patient who becomes psychotic and has history of lupus and is on steroids, and then you have to think, is it substance-induced psychosis because of the steroids, or is it due to the medical condition? And there's only one way to differentiate: increase the steroids. If the patient gets better, it's caused by lupus. Patient gets worse, it's caused by steroids. One topic that might show up on your test, I just want to touch on it, is delusional disorder. This is different from schizophrenia. This is that patient who everything's normal. The functionality is preserved, but there is one delusion present that the patient might keep going back. This is the patient that you have in your clinic for routine follow-up, the nice guy, married, has a good job, stable, but every time he visits you, he talks about FBI hiding next door to him and having cameras on him and spying on him. Everything else is normal, it's just that one delusion. Again, back to that chart, delusional disorder versus schizophrenia with delusional features. The differentiating factor is a decline in functionality. Antipsychotics are common medications that you will see a lot. Your patients will be on them. There are 2 classes of antipsychotics. We call them first generation and second generation. First generation, the most common name that you hear or will be on your test is haloperidol. In terms of side effects, the extrapyramidal symptoms, EPS, are more common with first generations. They can cause neuroleptic malignant syndrome, they can cause tardive dyskinesia, and they can cause lactatemia, there we go. The key thing to remember, first generation antipsychotics, Haldol, more likely to cause EPS, and in rare but life-threatening cases, neuroleptic malignant syndrome. Second generation or atypical antipsychotics, they're less likely to cause EPS. They're more likely to cause metabolic syndrome. They are more likely to cause weight gain. And they are less likely to cause hyperprolactinemia, except one medication. Keep that name back of your head just in case it shows up, risperidone. It has a very high rate of gynecomastia. As a matter of fact, I'm pretty sure some of you guys have seen the TV commercial for the lawyers. Have you been on risperidone and suffer from gynecomastia? Call us. We'll sue the psychiatrist who gave it to you. There are a few zebras in antipsychotics. The only antipsychotic that does not cause hyperprolactinemia, it actually decreases the prolactin, is aripiprazole. The only antipsychotic that does not cause EPS is clozapine. And the only antipsychotic that does not cause QTC prolongation is lorazepam. Clozapine is the gold standard of treatment in psychiatry. It is the only medication that not only it affects positive symptoms of schizophrenia, it also affects negative and cognitive symptoms. Unfortunately, other antipsychotics that we have in the market, they don't really touch cognitive symptoms of schizophrenia. However, it comes with risk of agranulocytosis. Please remember that word with that medication for your exam. And also remember, it's the only medication in schizophrenia that decreases suicidality, risk of suicidality. So we'll switch gears a little bit and talk about more medicine-related topics in life-threatening psychiatric medication side effects. This is probably the time that the psychiatrist calls you and tells you, I started the medication on something, I screwed up, yours, bye. And then I guess you're a little bit in trouble if a psychiatrist is telling you how to treat this condition. But the three important ones to remember are lithium toxicity, serotonin syndrome, and neuroleptic malignant disorder. A 36-year-old woman presents with agitation and confusion. She reports feeling well until developing a cold, a cough, and a cold yesterday. She was seen at an urgent care clinic and given a medication she does not remember the name. Her past medical history is significant for depression. Current medications are citalopram and bupropion. On exam, she's febrile. Blood pressure is a little bit elevated. Her pulse is elevated. She looks anxious, a little bit tremory on the exam, and she's hyperreflexic. Which medication is likely contributing to her condition? Acetaminophen, amoxicillin, dextromethorphan, ibuprofen, and azithromycin. Dextromethorphan, yes. Just remember that medication, it interacts with psychiatric medications and can cause serotonin disorder. We'll go into more details about this. So when you are thinking a psychiatric medication causing a life-threatening event, this is the story that you have. You have a patient that, number one, has to be on a psych medication, otherwise it wouldn't be the case. And the patient was stable on this medication and was working. Think of basic sciences. There is certain amount of medication coming in every day, and the patient is clearing certain amount of medication either through liver or kidney, going out every day, and everything is stable until something happened. And that equilibrium went way out of balance. That thing that happened can be an intentional or unintentional overdose. The patient just took too much medication. Or it can be a medication-medication interaction. The patient took one medication that kind of affected the metabolism or clearance of the other medication. Or it could be an organ failure. The patient was able to clear the medication before and now is not. So with lithium toxicity, remember, the diuretics can affect clearance of lithium. NSAIDs can cause that. The symptoms of a lithium toxicity, think cardiac, prolonged QTc and arrhythmias, a lot of nausea, vomiting, and diarrhea. Some CNS symptoms, confusion, tremors, seizures, myoclonic jerks, and renal symptoms, there is decreased renal functioning. In terms of managing the patient, stop the agent. ABCs, just like any other medical condition, fluids. Activated charcoal, just remember, does not work on lithium, so you probably don't want to use activated lithium. And if you are checking lithium levels and it's higher than 5, you probably want to send the patient for emergency dialysis. Serotonin syndrome, when you're thinking about serotonin syndrome, just think that there is too much serotonin-energic activity going on in the brain and in the rest of the body. The key words to remember: patient is on antidepressant, dextromethorphan here. You might have the patient whose favorite auntie told him St. John's wort work for depression, so you start a patient on antidepressant and they start taking this over the counter. Sumatriptan can interact with it, ondansetron can interact with it and cause serotonin syndrome. So keep in mind. In terms of diagnosing the condition, there is actually no confirming diagnostic labs. The symptoms may change from very mild tremors to life-threatening shock. There is a Hunter criteria, how to score serotonin syndrome, and I think the only important thing that you need to keep in mind is presence of clonus and hyperreflexia in your patient. In terms of treatment, it's mostly supportive care. If you have to have the patient in ICU, that would be probably a good idea. You can use benzodiazepines for managing the tremors, also for managing the agitation, and it also helps with heart rate and blood pressure. Continue cardiac monitoring your patient. And in terms of severe hyperthermia, you might consider intubating the patient. And of course, avoid Tylenol. Another condition that can be caused by psychiatric meds is neuroleptic malignant syndrome. When you're thinking this condition, remember there is too little dopaminergic activity going on, or there is too much dopaminergic blockage suddenly happening. You see it in patients who are on an antipsychotic, more common in first generations than second generation antipsychotics, or you can see patients on non-psychiatric meds. Another event that can cause a neuroleptic malignant syndrome is discontinuing Parkinson medication very fast. The side effects are, number one, organic brain abnormalities. If patient is not used to antipsychotics and you suddenly have a big dose going in, increased risk. For some reason, we don't know why, I would keep in mind. Low serum iron levels can be correlated with neuroleptic malignant syndrome, and also dehydration and lithium. The key symptom in this condition to remember is that lead pipe rigidity. And remember, because these guys have severe rigidity, there are a lot of muscles tensing up, so they have a lot of muscle breakdown. So on your labs, you will see that elevated CK. In terms of managing, kind of the same as serotonin disorder. Stop the agent, supportive care, fluids, because you want to wash that CK out. You can use benzodiazepines. And in your core, it was mentioned that ECT, electroconvulsive therapy, can actually be used for managing severe neuroleptic malignant syndromes. It's true, but I don't think it's being done right now. So when you're thinking serotonin syndrome and neuroleptic malignant syndrome, they're almost very similar disorders. It's really, really, really hard to differentiate. Even when I'm the psychiatrist and I get called in to evaluate a patient, to be honest, the only way for me to know is what medication patient was taking. They have a lot of common features. Tachycardia, hyperthermia might be present in both of them. Both are different from anticholinergic poisoning. Remember, an anticholinergic poisoning patient is very dry. In these two conditions is the opposite. Altered mental status is present in both of them. In terms of board review questions, you will see that lead-piped rigidity. On physical exam, to be honest, you cannot really sometimes differentiate that. So in terms of differentiating them, for serotonin syndrome, the patient was on a serotonergic agent. Neuroleptic malignant syndrome, it was a dopaminergic agent. In terms of timeline, serotonin syndrome shows up much faster, in less than 12 hours. It also resolves much faster, versus NMS, it takes 1 to 3 days to show, and it takes 1 to 3 days to resolve. In terms of reflexes, you have hyperreflexia in serotonin syndrome, NMS hyporeflexia. The pupils are dilated in serotonin syndrome, and also the bowel sounds might be a little bit different. But for the purpose of the board and your practice, the most important thing is what the patient was taking. Okay, next question. A 68-year-old man is brought to the ED by his wife for evaluation of fever and confusion. Past medical history is significant for Parkinson's and hypertension. He is on omeprazole, lorazepam, and Aripil. He stopped taking his levodoxa about a week ago. On exam, he's febrile, he's hypertensive, he's tachycardic, and he's diaphoretic. Also in the exam, you notice that he has marked muscle rigidity with hypoactive reflexes. On labs, you notice elevated white blood cell count and elevated CK. What is the most likely diagnosis? Parkinson's disease, meningitis, depression, neuroleptic malignant syndrome, or serotonin syndrome? Perfect. Yeah, neuroleptic malignant syndrome. So this is the classical case that the patient was taking a dopaminergic medication. The brain got used to good amount of dopamine, and then you had a sudden drop in dopamine. And that it acts like as if the patient took a high dose of antipsychotics. Substance use disorders, briefly we'll touch on them. There are stages of change every time you're talking to a patient about changing lifestyle. There is the pre-contemplation stage that the patient is not ready to quit. You talk to them about quitting, they don't want to do it. Contemplation is they have thought about it a little bit. They might consider quitting. Preparation is when the time the patient is actively planning to quit. Talking to you, yeah, I'm going to quit, I'm going to do this. They might actually set a date, a target date to quit. Action is when it actually happens. And then when it comes to substance use, never quit quitting. And never focus on the patient not using the substance for the rest of their life. The goal has to be to prolong that maintenance phase of change. The other way you can look at it is there is always a chance of relapse, and your goal is to postpone that relapse as much as you can. Nicotine, a very commonly used substance, about 10% of patients actively smoke. In schizophrenia patients, that's about 80%. Nicotine use is increased in all mental health patients. When you are focusing on nicotine use disorder, please also focus on mood disorders, anxiety, managing the stress. And remember, it's a potent parasympathomimitic, you know what I mean, stimulant. So when the patient quits smoking, it can have very significant withdrawal symptoms. In terms of medication, you can use nicotine replacement therapy, patches, or gum, or a combination of both. Varenicline is another medication used very often. It's a partial nicotine agonist. The common side effect of the medication I would keep in mind for the purpose of this test is depression and mood symptoms. And bupropion is also a medication that's used a lot for treating tobacco use disorder, and a combination approach of using all of these together rather than just one at the time would probably be the most effective. Alcohol use disorder. In terms of treatment, you can suggest psychotherapy. AA is very effective. Just like everything else, cognitive behavioral therapy works in psychiatry. In terms of medication, naltrexone is an option. It's an opiate antagonist. The counterindication is that you already have a patient on opiate for some other medical condition for pain. You probably don't want to block opiate receptors. In the brain, the way it kind of works, it blocks the reward pathway, and it blocks the opioid receptors in the brain so they don't feel rewarded from drinking. Acamprosate is another medication we use. Aldehyde dehydrogenase inhibitor is one of the more old-fashioned medications. You might see it in the test, but the key point, remember, naltrexone, the counterindication is patient is already on another opiate. In terms of alcohol withdrawal, the chance of seizure is usually the first 2 days. However, the first day, you can have alcohol hallucinations. There are other symptoms. Delirium tremens is very common. Agitation, very common. And the symptoms, the key point to take home is the symptoms can last up to 5 to 7 days after withdrawal. In terms of treatment, supportive therapy, consider use of longer half-life benzodiazepines. If you have a patient in ICU, you can consider using IV lorazepam. You can use anticonvulsants as an alternative, and also please give folic acid, vitamin B, and thiamine. In terms of opioids, psychotherapy, cognitive behavioral therapy, just like everything else in psychiatry, very effective. In terms of medication, methadone is a opiate replacement therapy. A very important take-home that might show up on your test is QTC prolongation with methadone. I would keep that in mind. And unlike alcohol, that withdrawal from alcohol can become a life-threatening condition, withdrawal from opiates is not a life-threatening condition. It's a very, very uncomfortable condition. So supportive care with managing the symptoms would be appropriate, but cocaine is a stimulant. It can cause tachycardia, tachypnea, agitation, psychotic features, The pupils, for the purpose of your test, I would just keep that in mind. The question might be, a patient comes in agitated, talking fast, tachycardiac, and the pupils, and what is the substance that he's using? The answer would be cocaine. When it comes to cocaine, always remember a myocardiac event is at elevated risk, and also that cocaine can cause a little bit of more muscle rigidity or make them very hyperactive. You have a guy who comes in, did cocaine, and then started running 10 miles. So keep rhabdo in mind and check for CK. And also a very common observation you have on your exam in a chronic cocaine using patient is the coke nose. Remember, cocaine is a vasoconstrictor, so it decreases the blood supply to the nasal cartilage, and at some point the nasal cartilage dies, and then you have a collapsed nose. Another substance commonly abused in the community is amphetamines, tachycardia, hypertension, anorexia, insomnia. A very common symptom in acute amphetamine use disorder is tactile hallucinations. These are the patients that come and tell you that they feel something crawling up on the skin. So when you're evaluating the patient on the exam, you see the actually scratch marks or lacerations on the skin from the aggressive scratching. Meth is a very, very acidic substance, so it reacts with the calcium in the teeth and kills the teeth and even the bone in the mouth. So the observation or the exam meth mouth that we see a lot is because of the acidic activity of the substance. Another substance that is used a lot in the community is cannabis. It can cause clinically significant behavioral or psychological problems. I think the most important take home for you guys is you will have the patient coming to the clinic telling you, I feel anxious or I feel depressed, and I was talking to my neighbor and he was telling me smoking cannabis is helpful, and the patient might be asking you for even giving a prescription in some states that now we have medical marijuana. If you look at the literature, in the long run, cannabis actually worsens mood disorders and anxiety disorders. Briefly touching on personality disorders, there are 3 clusters of personality disorder in psychiatry, cluster A, B, and C. I think the 2 important ones you need to know, one is in cluster B, borderline personality disorder that shows up a lot. And they can be sometimes difficult interacting with the provider, and obsessive compulsive personality disorder in cluster C. So what is a personality disorder? A personality disorder, I mean, when you're talking about depression, there is too little serotonergic activity going in the brain. Or if you're talking about psychosis, there is too much dopaminergic activity going on in the brain. In terms of personality disorder, you have a pattern of experiences and behaviors that the patient has. That pattern can cause difficulties with that person and another individual, individualistic behavior problems, or it can cause problems inside the patient themselves, causing mood disorders, mood symptoms. This is a life diagnosis. It's mostly caused by childhood events, how you were raised. And remember, when we are talking about personality disorders are not black and white. They are not either present or absent. Everybody has traits of personality. Everybody needs a little bit of narcissism. Everybody needs a little bit of obsessive compulsivism. It's not like pregnancy that you're either pregnant or not. It's not like either you're not narcissistic or you are. It's a trait. And now the question, it becomes a disorder when those traits cause significant amount of impairment in your daily functioning or your interactions with other people or interacting with yourself. When you're thinking cluster Bs and borderline personality disorder, they're at higher rate of substance use, there is elevated risk of depression, very poor impulse control and aggressions. Keep in mind a lot of black and white thinking, or the word that is used a lot is the splitting. And this is the only one time in psychiatry that instead of CBT, cognitive behavioral therapy, we use another therapy, DBT, dialectical behavioral therapy. A 28-year-old female presents to the clinic for changes in her mood. She reports she experiences multiple mood swings, sometimes up to 5 to 6 times a day. She sometimes feels high on energy, feeling great, motivated, wants to dance all day. Her mood, however, can change to very depressed and low energy within an hour, with urges to cut herself. She reports she hates her previous doctors because he made her wait every time she visited his office. She can tell by now that you are the best doctor ever and that you will be taking great care of her. What is the most likely etiology of her mood swings? Depression, cyclothymia, bipolar disorder, borderline personality disorder, or delusional disorder? Borderline personality disorder. So one of my most favorite ways of interviewing the patient, I always ask the patient, if this is average mood that most people spend, do you spend mostly up here or down here? If they answer mostly down here, the answer is depression. But I also ask the patient, do you fluctuate? Do you go up and down? And if the answer is yes, the second question I ask is how much time you spend up here? If you're up here, is it more than days? Is it like 7 days? That would be the case of bipolar disorder. They spend up there very often. But if the answer is no, I go up and down within an hour, and the patient might actually tell you, my mom tells me I'm very bipolar, I go up and down 5 times a day. That's not bipolar disorder. That is actually borderline personality disorder. And remember, there is a lot of splitting going on, telling you the last doctor was horrible and you're the best one, you're gonna take really good care of her, the mood swings, the energy changes, they're all characteristics of this personality. Obsessive disorders, there are 2 of them, obsessive compulsive personality disorder and obsessive compulsive disorder. You might want to know the difference. The obsessive compulsive personality disorder is your typical perfectionist person that they create rational thoughts about their obsessions. These are the patients that when you confront them about those obsessions, there's nothing wrong with them. Again, it's a personality trait. If you didn't have a little bit of obsessive compulsive personality, you wouldn't become a doctor. So it serves. But in terms of disorder, personality disorder, those obsessions affect their interaction with other people. Versus obsessive compulsive disorder, the patient is aware of the obsessions. They know that the obsessions are causing problem, and they come to you and ask for help to help with the obsessions. OCD has 2 components. One is the obsession that is causing severe urges or anxiety, and the compulsions are these repetitive behaviors to decrease the obsessions or the anxiety caused by them. It's the typical patient who comes to you and say, if I don't turn the light on and off 20 times in a day, I know that I'm going to have a bad day. So they start in the morning, do 1, 2, 3, 4, 5, and then when they get to 20, they're about to leave. They're like, oh, wait, was that 19 or 21? Let me do it again. And then they do it again, and they're about to leave. And it's like, but wait, now if I did 20 and then I did 20 again, that's 40. So that's not going to work. So I'm going to go take my clothes off, get dressed again, and start the day again so I can do 20 again. In terms of treatment for OCD, again, CBT, cognitive behavioral therapy, works. In terms of exposure, you can do some exposure and response prevention therapy. It's the patient that you tell them, okay, you're feeling worried about if you don't turn the light on and off 20 times, you're going to have a bad day. Let's not do it. Let's go have the day and see if you're going to have a bad day or not. And then in terms of medication, we use a lot of very, very high dose SSRIs. Topic of insomnia, sleep might come up in your test. The key point is, remember, there are 3 different types of insomnia. 1, you have a hard time falling asleep. 2, you have a hard time staying asleep. Or 3, you wake up too early in the morning and then you can't fall asleep again. When you're assessing a patient for insomnia, remember, if your patient is suffering from insomnia, there is an elevated risk of a psychiatric condition, depression or anxiety. Also, it can be caused by social or medical conditions not related to sleep. Address those conditions first. Tobacco use, chronic pain, restless leg syndrome, they can cause insomnia. In terms of management, again, remove the predisposing condition. Look at the medications the patient is taking. If it's a stimulating medication, maybe move the timing to morning time rather than nighttime, and sleep hygiene. Again, CBT works in psychiatry. You can do it for sleep. Sleep hygiene is very important. Discuss that with your patient. And in terms of medication, there are a lot of medications in the market. The benzos, non-benzos, antidepressants, antipsychotics, over-the-counter herbs, the anticholinergic meds, we use a lot of them for sleep. The key point is to remember, if your patient is having a hard time falling asleep, you want to use a short-acting medication. Versus if your patient is having a hard time staying asleep, you want to use a longer half-life medication. And also talk to your patient about how it affects their life. Trazodone is an off-label medication used for sleep a lot in the community. It has a very long half-life. So if your patient is coming to your clinic and having a hard time falling asleep and you give them trazodone, you did not resolve the insomnia, and then you probably made them groggy and drowsy the day after. Back to the point of shorter half-life versus longer half-life. Behavioral approaches and CBT would be the first line, and then medication would be second line. We'll briefly touch on eating disorders. Anorexia nervosa. The only thing that you really need to know about the exam is that these patients have very, very, very low BMI. And in DSM-4, amenorrhea was a criteria for this condition. In DSM-5, they removed it to include male patients. And also, you have an elevated risk of refeeding syndrome in a patient who is suffering from this condition. If it's very severe and they're admitted to the hospital for a feeding tube, you have an increased risk of refeeding syndrome. And also, they have a lot of electrolyte abnormalities, so think arrhythmias and QTc prolongation. As opposed to bulimia nervosa, these are the patients with actual normal or elevated BMI. This is the patient who binge eats and then feels bad about it and then tries to throw up. On the exam, because of the acidity of the stomach contents, you can see a lot of decay in the teeth. And also, one key important to remember, so these guys throw up a lot. They lose a lot of stomach contents. So they use a lot of acidity. So on their labs, they're going to be hypokalemic. When the hydrogen comes out, the potassium follows it. So they are hypokalemic and they're hypochloremic. It's the HCl, the acidity of the stomach. If they keep losing it, they're going to go down. They're going to run low on hydrogen, on potassium, and on chloride. Last topic, I promise, somatic symptoms and related disorders. Somatic symptom disorder is just characterized by feeling anxious, having thoughts, or having behavioral problems involving multiple organs. This is the patient who comes to you and has like a million problems. The history, the physical exam, the workup is not significant. You call the psychiatrist. There is not a psychiatric condition going on. There is no depression or bipolar or psychosis. In terms of management, have routine, scheduled, regular appointments with your patients. Make sure you talk to your patient. Your time is limited. Also, you're going to address only one symptom at the time at the visit, and also set limits for how much of workup and diagnostics you're going to order, because these are the patients who come to you and they're freaking out and asking for that MRI and a million other studies to perform. So set very reasonable limits for how much you're going to work up those symptoms. Conversion disorder is another disorder in that category. The very important thing for you to know is that the symptoms, the reported symptoms, are neurological symptoms. The majority of the symptoms the patient is reporting is either motor or sensory function. So if you're thinking back of your head, consult neurology, it's going to be conversion disorder. And after you do a complete exam and workup and consult neurology and everything else, the workup is negative, but the symptoms are still present per reported patient. Factitious disorder are medical or psychological signs and symptoms, and the main goal is to play the role of the sick patient or to play the role of primary caregiver to a sick patient. And there is no known secondary gain. Versus malingering is the symptoms, the reported symptoms don't make sense based on your exam, and the primary drive for those reported symptoms is secondary gain. It's either financial compensations or not going to work or military service or obtaining benzodiazepines from you. There are secondary gains. All right, that was entire psychiatry, an hour and a half. Thank you.